So, here is our roadmap for today. We'll kick things off with anatomy and congenital quirks, then move into cysts and horseshoe kidneys. After that, we'll tackle hydronephrosis, break down the actual science of renal stones, and finally look at exactly how modern medicine shatters those stones.
Okay, Section 1. Anatomy and congenital quirks.
Let's start with the foundational structure, because there's actually a profound difference between your left and right kidneys, especially when it comes to their veins. So inside you, the abdominal aorta sits slightly to the left, while the inferior vena cava, the IVC, sits slightly to the right. Because the IVC is on the right, the left renal vein literally has to cross all the way over to reach it. This makes the left renal vein significantly longer than the right one. Now, why does this matter to us? Well, surgeons absolutely love the left kidney for transplants. That longer vein gives them way more room to create an anastomosis, that crucial surgical connection to the recipient. Also, the left testicular vein drains directly into this left renal vein. So if a tumor happens to grow along the renal vein and block it, it can actually cause a secondary varicocele to pop up on the left side. Crazy, right?
And sometimes, the body's plumbing just gets duplicated. Imagine a young female patient comes into the clinic, and her mother says she has literally never been dry since birth. She suffers from continuous dribbling, and yet, here's the kicker, she can still pass urine normally. How is that mechanically possible? Well, it's because she has duplicated ureters. The ureter draining the normal lower part of her kidney goes right where it should, into the bladder, allowing normal voiding. But the extra ureter, the one draining the upper pole of the kidney, follows what we call the Weigert-Meyer rule. This means it opens medially and at an ectopic location. In females, that location is often the vagina. This completely bypasses the bladder sphincter, which is what causes that continuous dribbling. The fix for this? A surgeon goes in and simply reimplants that ectopic ureter where it belongs.
Moving right along to Section 2, cysts and horseshoe kidneys.
Polycystic kidney disease, or PKD, is a condition that basically turns the kidney into a mass of enlarging cysts, totally destroying its normal function. But there are two drastically different forms of this. Infantile PKD is autosomal recessive. That means you need a copy of the gene from both parents. It's linked to chromosome 6, and tragically, it is fatal very early in life, often because of hepatic fibrosis. Now contrast that with adult PKD. This version is autosomal dominant, linked to chromosomes 16 and 4. It usually doesn't even show up until the patient is in their 30s, often just presenting as high blood pressure in an otherwise healthy young adult. It can also cause cysts in the liver, which is the most common extrarenal sign, and really dangerously, it can cause baryaneurysms in the brain.
Then we have the famous horseshoe kidney. During fetal development, if the lower ends of a baby's two kidneys accidentally fuse together, they form a horseshoe shape. And as they try to ascend into their normal adult position in the body, they actually get snagged. They hook right under the inferior mesenteric artery and get stuck at the level of the L3 and L4 vertebrae. Because of this bizarre anatomy, there is one absolute, unbreakable surgical rule. Never cut the fused portion. If you do, you'll completely devascularize the lower ends of both kidneys, which is a disaster. There is literally exactly one exception to this rule, and that's if a vascular surgeon desperately needs to access a highly symptomatic abdominal aortic aneurysm that happens to be sitting right behind it.
All right, Section 3, hydronephrosis, or what happens when the flow gets blocked.
So hydronephrosis is essentially a massive plumbing crisis. The flow of urine is blocked, and it creates this dangerous back pressure that physically dilates and crushes the delicate kidney tissue from the inside out. When this kind of blockage happens, clinicians essentially have to act like detectives. They use an intravenous aerogram, or IVU, to hunt down the culprit, and they look for some amazing visual clues. For instance, if the terminal end of the ureter dilates into a ureterococele, on the scan it looks exactly like a cobra head. If a transitional cell carcinoma tumor is blocking the way, the contrast dye cups right around it, creating a distinct goblet sign. If the ureter gets trapped behind the IVC, which we call a retrocaval ureter, it gets yanked into a sharp fishhook shape. And if the ureters are being squeezed together by retroperitoneal fibrosis, it pinches inwards, creating what's known as the maiden's waist anomaly.
Once we actually spot the blockage causing all this trouble, the big question is this kidney too far gone? To figure that out, we use a MAG-3 scan to test the kidney's function. Specifically, we're looking at its differential GFR. Basically, how much is this one kidney contributing to the whole body's filtration? So, step 1. If the blocked kidney is contributing more than 20%, we fight for it. We go in and try to save it by fixing the blockage. Step 2. If it's hovering between 10 and 20%, we perform a nephrostomy to drain the fluid out, and then we just observe it to see if it recovers. But step 3. If it's contributing less than 10%,
Sadly, it's beyond saving, and a nephrostomy has to be performed to remove it completely.
Section 4. The science of renal stones. At its core, stone formation is just this chemical battle between supersaturation of products and the natural stone-inhibiting factors in our body, like citrate. But before we get totally bogged down in the chemistry, I have to share this brilliant historical quote from the classic surgical textbook, Bailey and Love. It goes, "A renal stone is nothing but a tombstone laid in the memory of the bacteria which lay beneath them." I just love that. It perfectly captures how certain types of stones actually form directly over chronic bacterial infections in the urine.
Okay, let's rapidly break down the 4 main types of stones. If a patient comes in and they just keep getting stones, we have to check out the microscopic crystal shapes. Calcium oxalate crystals, they look like tiny little dumbbells or envelopes. They form very hard stones with spiked, mulberry-like margins, which is why they cause bleeding and severe pain so early on. Next are triple phosphate or struvite stones. These are those massive staghorn paperweights we talked about earlier. They form in infected alkaline urine, and perfectly matching that tombstone quote, their microscopic crystals literally look like coffin lids. Then you have cystine stones, which feature a hexagonal lattice and are just incredibly hard to break. And finally, uric acid crystals. These look like tiny shattered glass shards. Notably, uric acid stones are radiolucent, which is a fancy way of saying they are completely invisible on a standard X-ray.
Now, these stones can cause some truly incredible mechanical phenomena in the body, most notably something called Diettl's crisis. Imagine this. A stone gets lodged and perfectly blocks the pelvic junction. The kidney starts filling up with urine, swelling immensely, and causing absolute agony for the patient at the renal angle. But then, all of a sudden, the stone shifts. The blockage is cleared, the massive internal swelling instantly subsides, and the patient suddenly passes a huge quantity of highly diluted urine. It's an incredibly dramatic release of plumbing pressure.
And that brings us to Section 5, shattering the stones.
So how does modern medicine actually get these painful rocks out of a human body without resorting to invasive open surgery? Well, the first line of defense for a symptomatic stone is ESWL, extracorporeal shockwave lithotripsy. It works entirely on blast wave dynamics. Think of a superhero in a movie punching the ground and sending this massive, visible shockwave rippling through the earth. It's kind of like that. We target the stone using ultrasound, and then we fire high-energy acoustic shockwaves from outside the patient's body. The sheer force of those waves traveling through the tissue shatters the hard stone into tiny fragments. And then, those little fragments just safely wash out naturally in the urine.
Sounds like magic, right? But unfortunately, we can't just use shockwaves on everyone. You absolutely cannot use ESWL during pregnancy, or if a patient happens to have a pacemaker. You also can't use it on fidgety children who simply won't stay perfectly still because the targeting has to be incredibly precise. Crucially, you can't use it if the urinary system is already obstructed further down. If you shatter a stone then, the fragments will just pile up and cause a massive traffic jam called a stone street. And finally, pure physics dictates we have to avoid it for stones sitting in the lower calyx, which is the bottom pocket of the kidney. Even if you shatter a stone perfectly down there, those tiny fragments have to fight gravity to travel up and out of the kidney, which often fails.
So what happens when ESWL is off the table, or the stone is just too stubbornly hard, like a cystine stone? We move to Plan B. We go in directly. For really large stones or heavily obstructed systems where the kidney is totally ballooned up with fluid, we use PCNL, or percutaneous nephrolithotomy. That's a mouthful, but it literally just means cutting into the kidney through the skin. We puncture a tiny little hole right through the patient's back directly into the dilated kidney, slide a scope in, and grab or blast the stone. Alternatively, we use URS, or ureteroscopy. This is where we take a tiny, flexible camera and literally navigate all the way up the body's natural plumbing, through the bladder, up the ureters, until we find the stone, trap it in a tiny little wire basket, and just pull it right out. Before we wrap up, we have to mention what happens when all this plumbing we've been talking about starts running backwards. That's called vesicular-ureteral reflux, or VUR. Instead of urine flowing safely down to the bladder to be excreted, it shoots back up the ureter towards the kidney. We grade this on a scale from 1 to 5. Grade 1 is just a simple reflux into a totally normal-looking ureter. Not great, but manageable. By grade 3, however, the backflow is causing mild distension or stretching of the renal pelvis. But if it gets to grade 5, the back pressure is so immense that there is gross distension, a complete loss of the kidney's normal papillary impressions, and a really severe risk of permanent renal scarring and chronic infections. And that brings us to the end of our anatomical journey today. From ectopic ureters entirely bypassing sphincters to microscopic glass shards that somehow turn into massive staghorn paperweights, the human kidney truly is a masterclass in biological engineering. It honestly kind of leaves you wondering, what mysterious plumbing secrets is your own body hiding right now? Thanks so much for joining me on this explainer. Remember to keep your body hydrated and keep learning.